What happens when the surgeon becomes the patient? Today on the Health Exchange, we're talking with a doctor whose own devastating accident reshaped everything he thought he knew about medicine, recovery, and resilience. I'm Dr. Jay Rutland, and I'm joined by orthopedic surgeon Dr. Steve Mora to talk about orthopedic surgery, but also the experience that changed the way he practices medicine. We're going to get into this right now. Steve, thanks for coming today.
Thank you, Jamie. Really appreciate you having me here.
Yeah, and you don't mind I call you Steve. I mean, I can do Dr. Mora, but...
No, I prefer Steve, actually.
Okay, good.
I actually prefer that.
Excellent.
Yeah.
So you practice orthopedic surgery. Are you in the area?
Yes, I am. I'm in Orange. I practice orthopedic surgery. I'm a board-certified orthopedic surgeon with fellowship training in sports medicine. So that means that I do a lot of arthroscopy, and I take care of a lot of sports-related trauma.
And what drew you to orthopedic surgery originally?
I think that the main reason why I went into orthopedic surgery was for me to be able to help people that suffered similar injuries that I suffered. And it goes back to my childhood. I was involved in a very serious car accident. It was actually a bus. I don't say bus all the time because I think people aren't going to believe me, but actually I was run over by a bus. And it happened when I was around 5 years old. It led to some devastating lower extremity injuries. So both of my knees or legs were actually crushed. So thank God nothing else was injured, just both legs. And I went through a series of treatments, including numerous surgeries in Peru initially, and later on at Shriners Hospital for what was called crippled children back then. I was a patient at Shriners in LA for so many years. And in that time period, during my experience as a patient, I experienced profound compassion, kindness, caring, and more than anything else, the orthopedic experience as a patient, and then seeing and experiencing this made me want to be one because I felt that I had the ability in a way, but curiosity. It was more intellectual curiosity about orthopedic surgery and also the desire to help people that have suffered similar injuries as I had.
Do you continue to have surgeries, or were all your surgeries done by the time you were 9 years old and you haven't had one since?
Yeah, my last surgery was when I was 18 years old. That was my last surgery at Shriners Hospital because it is a children's hospital. A couple of years ago, I had a soft tissue surgery because I have some scar tissue. It was all done to prepare for the future knee replacement. I had some screws removed and I added some adipose tissue.
How many surgeries did you have from 5 to 18?
I've had about 7 surgical procedures. The main one that I had was actually quite interesting. One of the main surgeries I had was a leg lengthening. Have you ever heard about that?
I've heard about it. Tell me how it works.
It's an amazing procedure, and I had it done when it first came out. The technology that was used for me was called a Wagner device, which is just an external fixation device that was placed in my femur. And since then, there's been some other techniques called the Lizaroff that came out later on. But it was in the early 80s. My leg was 9 centimeters shorter, like one leg.
Oh, wow.
And I'm going to tell you a fun fact here, okay? Like, how tall are you?
6'1".
Okay. And can you go like this? Like, okay. So we are about the same height, right? We're looking at each other eye to eye right now, right? That's because I was meant to be a 6'1" person as well. But if we stand up, I guarantee you, you're taller because my legs are shorter. And my legs were made shorter, actually. Surgically, they were actually made shorter. One leg was outgrowing another one. My left leg was outgrowing my right leg. So I got to the point that it had a difference, like a 9 centimeter difference, So they had to slow down the growth of the rabbit, the fast one. They slowed it down. Actually, they stopped it. And that way the difference wouldn't get any worse. And then once they stopped the growth of the fast one, the shorter one was extended. It was elongated to catch up.
How do they do that?
It's an amazing procedure. What they do is they'll cut the femur, which is the femoral shaft.
Mm-hmm.
They'll saw it in half. Okay, they'll just take a saw and cut it right in half. They'll place 2 pins above the saw cut and 2 pins below the saw cut. And these are really big pins, like bolts. And then they attach it to a telescopic type of rod on the outside of your leg that can telescope open. So initially it's a certain length, and there's a knob that controls the length of that rod. Right? So every day you turn it, and every day it opens up the gap in the bone. It spreads the bone apart.
And then you heal.
It heals by itself when everything works
by
well.
Primary intention.
It fills in. It fills in, and that device is kept on there until the defect is filled with bone. It doesn't always fill with bone. Sometimes you have to bone graft it. But that was an amazing procedure. It was done at Shriners Hospital. If that doesn't pique your interest in orthopedic surgery, it's amazing that the body just knows it has to fill that defect. Like there's some signal that occurs, where there's a little cell, where there's a platelet that releases its growth factors, and all of a sudden it sends the Marines in and it fills it in. It's amazing what the body does.
That involves, because bone marrow has a lot of blood, right? That's where all the
Yeah.
blood cells are made anyway. So you have all your blood cells there doing that. But it's kind of like, how do you do that same thing for the cartilage or for, I guess, my terrible patella tendons that hurt like hell? Like, why can't I just replace those? So your personal philosophy when it comes to caring for patients sounds like originated during your stay at Shriners.
Some of it did. And like I said, there were a couple of reasons. And another reason was that I loved tinkering with things, mechanics, machinery, electronics, or my fishing reels. I'm an avid fisherman, and I loved taking apart my fishing reels and putting them back together, which was very difficult as a young person. And so Shriners was, I think, where the seed was planted. As I grew, I realized that I did have some skill sets that squared up with orthopedic surgery, including putting things together, using tools, and working with my hands. I felt I was quite good, actually.
Ortho has evolved over the last 20, 30 years. How have you seen it evolve? What particularly impacts you on a daily basis where you're like, well, I can't believe we're doing this now?
Yes, initially, and during training, we do a lot of fracture fixation, learning about the biomechanics of plates and screws and external fixators. But as time has gone on, we now focus on the biology, the biologics of healing, understanding growth factors, and understanding what platelets do in stem cells. But now even more so, and it hasn't really been picked up by all orthopedic surgeons, but we're starting to understand how metabolic health affects joints. So it's gone from hammers, screws, saws, routers, to now trying to have a better understanding of why it's happened, what we can do to prevent it, and how we can bring in biological treatment options to help people heal.
One of my favorite attendings, I went to University of Iowa for medical school, and Iowa has a strong orthopedic surgery
Yeah.
program. And Jody Buckwalter was the chairman then, and he was our, like, whatever we called him, PBL. He was our PBL leader when I was a first year medical student. So I got to shadow him and spend a lot of time with him in the operating room. And he studied a lot of oncology and cellular communication and what led to the cancer, how the cancer spread. We're talking about orthopedic cancers. And it was the first time where I had actually heard an orthopedic surgeon really talk about the science of cell communication and how that contributed to their field. And it sounds like you have got a tremendous interest in that as well.
It's not only because of my 23 years of experience of seeing how people's metabolic status affects their joints, but it's also through my own understanding of my own pain that I've been going through. But especially the last 5 years, things have gotten worse. I've been able to experience how certain injections can help, like plasma injections or stem cells or even fat injections, and then my own interest to learn about these things as well.
When you're talking about what you're going through now, which stems from the accident you had, do you remember as a 5-year-old, like exactly what happened, what you were doing, or is it all kind of like a blur and you just kind of remember being in the hospital and recovering?
It's like a dream. When you wake up from a dream, you remember certain parts. It's hard to chain it all together sometimes. That's how it is. There are little vignettes or little things that I remember as a child that were impactful. I remember seeing like bleeding through a cast after a fall. So there's certain things that had impact, just like they do now. Certain things you will remember the rest of your life. And there are certain things like that are actually quite traumatizing, actually.
Just thinking about the age of injury, which was 5 for you, and you kind of going through the ages of 5 to 18, going through puberty, going through high school. I mean, it had to be taxing to deal with watching some of your friends being able to maybe, I don't know, do some things or athletically or something that you were just, I mean, how did it affect you growing up? It just seems like something like that, injury like that, an accident like that would really have a psychological impact.
That's great insight. Yes, I was not able to participate in the PE that everybody was able to, but interestingly, I didn't really see it as a problem. the fact that I couldn't really run like everybody else. And I try not to look at it as a negative. It brings me strength in a way where I try to figure out how I can do something to get around those issues, you know? So even though I couldn't run very well, I still participated in 5 and 10Ks, and yes, it would hurt afterwards, but I felt that it was important for my health. And during residency, just to stay in shape, I would go up and down the stairs, like 13 floors just to stay in shape.
Right.
And I think it's part of my makeup, and that's probably why I did well as a medical student. I always tried to be the very best I could possibly be and not look at my problem as a problem, but actually something that would give me strength because I needed to work around it.
Yeah. Was there anybody then that told you that, or is that just something you developed on your own? Was there somebody next to you that was like, hey, Steve, you got to think about it in this manner?
I wish there was. I think it's just, I came here to this country when I was 7 years old. My father worked in a paint factory and my mom worked in an assembly line. And I think I just thought, I think in this country, you just have to just go hard, go hard and figure things out and study harder than everybody else and do everything the best you possibly can and preferably better than anyone else. And it was just like a gene inside of me.
Hearing your story and what you went through as a child, and then being able to say to yourself, I still need to work harder than you, even though I have certain limitations. That's inspiring. And I hope it's inspiring for you guys just to hear what Steve had to go through and to be able to accomplish what you have now being an orthopedic surgeon, has been practicing for 23 years. When you see a patient, do you think that your history of your childhood injury has made you more empathetic to patients like during their first visit?
I understand the pain that people are going through, and I understand how it affects them on a day-to-day basis. And I can't say that I understand 100%, but I believe that it makes a difference when one has experienced what others are going through. And I don't like to say, look, I did it, you can do it. I'll never say that. I'll say that I understand what you're going through. I understand how it's hard going downstairs or upstairs or you can't lift your child, If you tell them that, they feel at ease that you're listening to them. That's number one. You are listening and you care. That's how it's helped me as a physician who has been a patient, who's been through numerous surgeries. And even when at the time of surgery, I will tell a patient, look, I'm sure you're nervous. That's normal. I was nervous when I went through my 7 surgeries. I was nervous. You let them know, I'll be with you through this whole thing. Because I understand how you're feeling.
Do you feel like you see a lot of patients that feel unseen or unheard when they're talking to you and they're in your office about their injuries?
Yes, because some of these complaints might seem mundane. Like let's say you can't bend your knee very well because you have pain. Well, I'm not sure if you've experienced this, but if one can't bend their knee very well, it can affect the way you walk downstairs. It can affect whether you can sit in the back seat of a car or a front seat of a car. It can affect whether you can go on a Disney ride. Actually, you can't. So sometimes these complaints that seem like they mean nothing to others, to me, they mean a lot. And I've had other injuries as well. My belief in life, or my credo in life, is to help people who have been told that they can't be helped. Okay, so to provide hope, because I went through a life of uncertainty and pain and hopelessness in a way. So I know that a lot of people come in and they'll say, hey, I was told there's nothing can be done. I wouldn't tell someone, hey, there's nothing that I can do for you. But patients are told that all the time, okay, for some reason or others. And maybe there are some cases that there's not much we can do, but one thing we can do is listen, number one, understand them, number two, and provide maybe options that other people haven't, especially biological options. And in my field, and I'm going to tell you a little story about something that has to do with hope, okay? I get tons of patients that come see me that have pec tears. You look like you lift, so you've done bench press, right? And bench press is the number one cause for pec tears. Pec tear is a tear of your chest.
My trainer has one right now.
Yeah. And if that pec tear isn't repaired within 6 to 8 weeks, it will never be repaired, actually. At least it won't be repaired by most people. So because of my training at LA County USC, we we had amazing trauma training, and I used the foundation of that training to help people with chronic pec tears, even tears that are older than 20 years old. So I came up with my own technique. Now, I'm not going to talk about my technique necessarily, but I'm going to talk about one thing. These patients, all of them, come to see me and they say, my doctor said there's nothing they can do for me. When I tell them that I can help you, and I have a technique that I'm able to fix these tears, I mean, some people will almost cry
Yeah.
because they've been living with a deformity, a chest deformity that to some people may not be a big deal, but these guys are usually athletes and aesthetics is very important in their life. They just had like a partial death in a way, like something has been removed. It's kind of sad. It's kind of sad, but it is one area in this field that goes beyond my own accident, but it's part of my credo of life and belief that I'm about providing patients hope.
I mean, how many times have I been told, oh, you just got a bad set of patella tendons, right? It's just the way it is, like a billion times, right? And so it's just hearing you talk to your patients in a way that provides them with hope is very comforting. After spending 30 minutes with you right now, that I can see what that visit would be like in your office, in your own space. And I think that's really, really, really important. When it comes to listening to patients and you hear them talk about their injuries, then from an orthopedic perspective, you always want to align some type of image to what their complaint may be. In your field, what's the most common imagery that you're looking at on a daily basis?
Shoulder pain, knee pain. It actually depends on the demographics. So if we're talking about a 45-year-old plus, it's going to be usually knee, shoulder related. If the person is like a diabetic or pre-diabetic, rotator cuff disease, younger person will have patellofemoral joint disease, maybe some meniscus tears.
Yeah.
And then my bodybuilders, I have a couple of different patient demographics. I have bodybuilders, and then I have UFC fighters.
You have bodybuilders and UFC fighters?
That's my niche. My niche, actually, I just basically gave you the spectrum of my patients. Is from, the weekend warrior to the market worker that's pre-diabetic, a consultant for the UFC, so I take care of a lot of the fighters.
Yeah.
I've operated on probably the many UFC fighters that you see on TV.
These UFC fighters, right? They're hitting people in the face, throwing them on the ground. These bodybuilders are taking their joints through like so many different things while taking all the supplements or whatever you want to call them they take on it. Like, what do you say to these guys that are just beating each other up, beating up their joints? The whole point of their sport is to hurt people. Like, how, like, no, seriously, like, how do you talk to them? Like, what do you say? So they come in your office and they're like, doc, my shoulder hurts. Like, well, I saw it on ESPN. You got thrown against the goddamn cage. Like, what do you say to these guys? Like, how do you talk to them?
Their point is to win.
Yeah.
The point is to win and put food on the table, right?
Yeah.
That's the point. So I understand what they have to go through. As a person that comes from working class people, we know, we saw our parents go through this. You got to just go to work and get things done. So my job is to help them get through their injury with or without surgery, hopefully without, so they can start their next camp and start fighting and fight again, so they can show and win. And if they do need surgery, I call it a bulletproof repair, because they are going to not follow instructions. Not going. It actually has become a great experience for me, because I've learned through trial and error when dealing with the surgical part of treating UFC fighters, is that the repair has to be rock solid. It has to be rock solid, because none of this 6 weeks of non-weight bearing stuff. They are going to bear weight at 3 weeks. Why? Because they have to. Their contracts are 3 or 4, maybe 5 fight contracts. If they lose 3 fights, they're going to be done. They won't be given another contract.
Oh, wow.
And I'm dealing with the fighter right now. So you have to be sensitive to the situation, that they have a lot of pressure on them. So the UFC fighters are very different than the professional boxers who are making millions and millions and millions, and they can be off for a couple of years. No big deal when you have $10 million, for one fight. These guys are not getting paid that way. They don't get paid that much money. Not like that. So then it's more important for them to be treated in a way that's effective, efficient, and get them back into the octagon. So it's the approach.
That's interesting because what you're bringing up is an element of shared decision making that people don't really think about, which for
Yes.
you, it's really like for UFC fighters, it's contract based
Yes.
in addition to injury based decision making, which is like, it's fascinating to think about it in that
Yes.
way. And having somebody like you that understands the injury, and I'm sure they're tearing a lot of pecs, that understands the injury and understands the implication in terms of how it's going to affect their ability to put food on the table for their family. You're doing this on a daily basis.
On a daily basis. And the reason why I have this patient population is because they know that I understand. They know that I understand. That's what's very interesting about my practice. You go into my office, you might run into a famous UFC fighter. You might run into a huge influencer on YouTube who just tore his pec,
Yeah.
or,
Yeah.
or a local police officer, or the señora from the grocery store.
When you're treating these individuals and they have surgery, they have orthopedic surgery, there are, and even if they don't have surgery, I'm sure there's non-surgical options like physical therapy. Is it effective? Is it not effective? Lifestyle modifications, injections. You balance all of this together.
Yes, it's great. It's so exciting to do that. It's exciting to be able to have all these tools available and not limit my tools to just a scalpel, but also use my network of people that I know that are involved with treating, whether it's chiropractic, physical therapy, people that do shockwave therapy, people that do stem cell therapy, and use that network to help people. And sometimes people may not have the ability to pay for some of these things. So you have to be flexible too. I've opened up a new office that's a very cost-effective office for platelet-rich plasma.
Platelet-rich plasma and peptide treatment. Tell me what that is, what it's used for.
Peptides are small chains or short chains of amino acids, like glucagon's a peptide. And then the GLP-1 medications are peptides. So peptides are well known right now in the fitness community because there are certain peptides that promote healing. BPC 157 and TB 500. These are the healing peptides. And then there are other peptides that will rev up your growth hormone production.
So they stimulate growth hormone production.
So instead of receiving exogenous or testosterone or growth hormone, which will lead to a negative feedback loop that'll stop your own growth hormone, you're just revving it up a little bit, And with the GLPs, which are very popular right now for weight loss, I do prescribe those because weight leads to central obesity, which leads to dysfunctional metabolic health, cardiovascular disease, type 2 diabetes, right? And guess what? It also leads to joint pain. So it's one of the tools in my toolbox. And to make it easy for patients, I'm all about giving people options because I understand that people come from different, or they have different resources.
Yeah.
I will provide treatments like PRP. I can do PRP in a very cost-effective way for people because I think people deserve to receive treatment that can help them without breaking the bank.
Yeah, what people don't think about when they think about adipose tissue or fat cells is they think about it's just about the weight of the fat cell. It's not just about the weight of the fat cell. It's about the function of the fat cell. And fat cells are very inflammatory. They produce a molecule called interleukin-6, which increases your inflammation. And we know those individuals that have more of those fat cells are more likely to have inflammatory diseases like cardiovascular disease, like diabetes. So when you use molecules like glucagon, like peptide, GLP, when you use those molecules to basically stimulate your brain to tell you you're not hungry, you're going to lose and shrink the size of that fat cell, which leads to less adipose. And it turns out this molecule is not just helpful for weight loss. It's helpful in cardiovascular disease, chronic kidney disease, Alzheimer's disease we've seen. So these inflammatory conditions, we can see how helpful molecules like the GLPs have been. And it sounds like in your practice, there are other peptides that can be beneficial for other types of things, like you're using them for supplements or for stimulation of growth hormone, and you've embraced that. Platelet-rich plasma therapy, what is that and what does that do?
Platelet-rich plasma, better known as PRP, is a treatment that will use your own healing potential to heal or promote healing of injuries or decrease the pain associated with degeneration. Now, how is it obtained? Well, it's your own platelets. So PRP, platelet rich. Why is it rich? Because the platelets are concentrated into a small volume. How is it done? We do a blood draw. We spin it numerous times. There are different methods of obtaining it. And then it's injected into the site with precision, either with an ultrasound for guidance or a fluoroscopy for guidance. And now, after about, I'd say, 20 years of existence, the research is showing that high concentration, not low concentration, but a high concentration injection of good quality platelets can reduce the inflammatory milieu in the joint, so decrease pain. There is a protein in the plasma called alpha-2 macroglobulin that is a protease inhibitor. So it will actually decrease the effect of metalloproteinase, which is an enzyme that will destroy cartilage. It might even be in the lung, maybe. I'm
Yeah,
not
there's
sure.
there's different matrix metalloproteinases. Yeah, yeah.
So it's so exciting to know that PRP, which is currently being used for tendon tears and arthritis, it might even have a preventative role for arthritis in the future because of these proteinase inhibitors. So that hasn't been done yet. But I'm super interested in this.
Yeah.
Actually, I've been interested in this. Let's go back to my knee injury, because I have this terrible arthritic knee. It's called post-traumatic arthritis. So I've been a guinea pig. So for the last 15 years, I've been getting all types of injections into my joint. I've had fat injections into my knee, but not actual fat. It's a little different. Also bone marrow injections into my knee and platelet-rich plasma into my knee. So I've been interested in it, and I adopted it and embraced it for years.
Now it's time for What's the Buzz, presented by BuzzRx. Every week, I answer a health-related question from one of our viewers. This week's question: Dr. Rutland, I'm on Fosamax for osteoporosis, and my orthopedic surgeon explained that I need to be off of it for a time period before and after a planned surgery. How come? Great question. Here's the answer. Fosamax, or alendronate, is a bisphosphonate that really helps in osteoporosis. The way it actually helps is it inhibits the breakdown of bone, so you get more bone build up. But when you're healing from a surgery or even from an injury, bone cells need to communicate with each other, and potentially Fosamax can get in the way of this communication and delay healing. That's the buzz. If you have a question, email us at healthexchangepodcast@gmail.com. Thanks again to BuzzRx. Look up your medications on BuzzRx.com or the app to see how much you can save. I want to go through just a quick rapid fire here.
Sure,
So I want you to be quick with the
Okay,
answers.
you got it.
All right?
Do that.
Most used tool in surgery.
A scalpel.
Okay. Worst orthopedic injury you've ever seen.
Open fractures, fracture dislocations, crushed hands. Those are some of the most grotesque that I've seen.
Favorite athlete to work with. You don't have to mention a name, but maybe type.
One of my favorite athletes, Michael Bisping, is one of my favorite guys. From UFC. Tony Ferguson, UFC fighters. My UFC fighters are absolutely great.
What's your favorite surgery to perform?
Chronic pectoralis major tendon tears in patients who've been told there's nothing that we can do for you.
Least favorite injury to treat.
Back injuries.
Tough.
Yeah.
Those are always tough. Right? 90% of all back pain goes away in 6 weeks. That's what we say most of the time. What's one joint you think gets overlooked?
The AC joint is overlooked because it's a great mimicker of neck pain.
Yeah.
So a lot of patients will end up getting neck surgery when all you had to do is treat the AC joint.
So the AC joint is the acromioclavicular joint, yeah?
Yeah, it's located right here.
Yep.
It's a great mimicker of neck pain. So the pain will go here. So the patient will either have a neck surgery if they go to a neck surgeon, or if they see someone like me, we'll just do a little injection and treat it.
So what you're saying is if a patient's having chronic neck pain, make sure that we look for AC joint
Definitely.
injury.
It's a great mimicker of neck pain.
The best recovery advice you give, but people always ignore. UFC fighters, I guess.
The best recovery advice is sleep. You have to sleep to heal. You have to sleep to heal, and you have to have good nutrition as well. But sleep is probably the most important.
So do you need more sleep when you're healing than typical? Like how many hours of sleep would you recommend to somebody?
7 to 8 hours.
7 to 8 hours.
But did you sleep 7 to 8 hours during residency or fellowship?
No, like 4, 5 tops, right? I mean,
5 is.
if you want to be a good student, like you're not sleeping
Yeah.
all that much.
Yeah.
If you want to be average, I mean, sure, go ahead and sleep all you want.
You slept a lot.
Oh man, look at that. When you think about post injuries, right? Like you've had, reduced movement can do a lot of damage, right? You can gain weight, you can develop metabolic issues. How do you overcome that?
It has to be a conscientious attempt. And the patient has to be given the green light to do it. So if a patient is not told to be active, the default is to not be active.
Yeah.
That's the default, because they will think that they're not supposed to do something. So I tell patients the worst thing you can possibly do is sit on a sofa in a dark room and watch TV and eat Doritos. That's the worst thing you can do for your health, actually. So when I do surgery on patients and they are having problems with ambulating or moving, I tell them the best thing you can do is go to the park, get some sunlight, get some vitamin D. It'll improve your mood, but you have to tell the patient that they can do it. You have to give them permission.
In your experience, because I know that you've had a lot of injuries and you probably suffer from some form of pain, so chronic pain, when you're operating and you're standing up or in your certain position for hours, I mean, it's got to hurt. Do you have like a chair or a stool that you bring with you into the operating rooms where you're doing it?
No, opposite.
Yeah.
Opposite. No, I tell myself that if I sit down, I might end up wanting to sit down like for the rest of my career.
Mm.
So you have to challenge yourself. I tell myself all the time, okay, I have pain. The worst thing you can do is not move, because you'll end up with osteoporosis or osteopenia, weak muscles, weak ligaments, and then you will be worse off. So I force myself to stay standing, even though some of my colleagues sit, especially hand surgeons, they love sitting. I think that it helps my posture, and even though it is painful, it is something that you just have to do, or else things get worse.
Selfishly speaking, there are certain things that I hear out there. And so I want to kind of go through a little myth busting with you. And I just want to know if people are wrong about this, right about this. I want you to tell me what's what. So here's the first thing. You should avoid moving an injured joint.
No, a joint will become scarred up, internally scarred up. It's called arthropfibrosis. And if the joint does not move the way it was designed to move, it will lead to abnormal pressure within the joint, and something will wear out. I mean, if you had an Achilles tear, that's different. Then you don't want to stress the repair. But in terms of the joint, like an ankle sprain, yeah, you rest it for a couple of days to get the swelling down, and then start moving it. Most cases. Okay.
So orthopedic surgery doesn't mean a month of bed rest.
Absolutely not. Opposite. Movement is life, and life is movement. That's actually something that sports medicine physicians live by.
You only need orthopedic surgeons if you break or tear something.
You only need an orthopedic surgeon when your grandma falls down and breaks her hip. That's when you really need the orthopedic surgeon.
Yeah.
You're not going to call anyone else.
Yeah.
You're going to call the orthopedic surgeon, right?
Yeah.
When you have fractures, you need orthopedic surgeons. I think that it depends on the orthopedic surgeon. If the orthopedic surgeon has a more global look, and it depends on their training. I have colleagues that are trained at joint replacement. They're like mechanics. And thank God we have great mechanics out there that can do a great joint replacement. Then there are the non-operative orthopedic surgeons, and then there's the hybrids like myself. I'm a hybrid. I do surgery, and then I love being able to help patients not have surgery and still do really well. But no, I think that it depends on the orthopedic surgeon, actually.
Yeah, it's interesting because when I refer people to ortho, they're like, well, I need the image and I need to know if there's something to operate on. And I'm like, I just need you to evaluate their joint. I don't do this. I need to know like what this patient's options are. Like, I'm not just sending them for you just to, broken fracture I need to fix. Like, it's got to be more than that. So I appreciate you saying that there is more than that.
So what you want to do is find out if they are fellowship trained in joint replacement, because if they are fellowship trained in joint replacement, they are excellent technicians.
Yeah.
And if you kind of want to have a different viewpoint, you may want to send them to a sports medicine type of orthopedic surgeon.
Here's another one. Cartilage can't heal.
Cartilage does not have a blood supply.
Right.
Okay, so cartilage has a hard time healing, just like a diabetic wound. But as we've learned with diabetic wounds, you can still get a diabetic wound to heal with certain treatments like amniotic tissue. You place the amniotic tissue, and guess what? Voila, it heals, right? So we're getting to the point that we can get cartilage to heal. There are technologies out there now that we can heal cartilage injuries. It depends on the type of cartilage injury. However, we're talking about a degenerative joint, one that is kind of globally worn out, thinned out like a car tire, that the tread is really thin. Maybe we can't get that joint to grow cartilage, but with certain treatments, we can make it so that so it doesn't hurt.
This microfracture surgery that everybody was getting in the NBA years ago, or I guess even now, is that supposed to be stimulating your cartilage to heal? What is that exactly?
That falls in the category of bone marrow stimulating techniques. And that's one where you're making little tiny little holes in the subchondral bone. The blood will then come out and pool within the defect. And if the environment is just right, that blood turns into like a jelly-like form, and then eventually it hardens and it forms what's called repair cartilage. Repair cartilage is not as durable as your normal cartilage that you were born with. It's okay, but not as durable. So we're moving a little bit away from that type of bone marrow stimulating technique and using other techniques now that can fill it with something more reliable.
What's replaced it?
Fresh osteoarticular grafts, where we take little plugs. It's real fun to do because you're actually making a little hole like a dowel, and you're filling it in with a plug that's made of bone and cartilage. They just came up with a plug that's made out of coral calcium, and it has bone marrow stimulating type properties that will create cartilage.
And you just put it
Just
right
pop
there?
it in there, but it comes down to the type of defect. Once again, if it's a diffuse degenerative type problem,
Yeah.
then that's a little different. But if it's a traumatic defect, something that we see in athletes, like a basketball player or something
Right.
like that, you can just feel it.
When you are walking throughout your life and you're doing your thing on a daily basis, do you think about what's happened to you in the past, or do you just move forward? Like throughout your journey, do you think, oh, man, this sucks? Or do you just kind of keep moving forward? Like, are there highs and lows in your own journey, or?
I don't dwell on the incident. I focus on how it's affecting me, like the pain pattern, when it happens, how it happens, the progression. And it's more so that I can understand it better and, of course, help my patients too. But, just for your information, I've gotten to the point now that it's going to affect my general health because I can't walk miles anymore. So I've decided to have a joint replacement, which I'll be having in December.
Which orthopedic surgeon did you pick? I'm just kidding. I mean, that would be a question.
He's not around. He's in a different part of town.
He's in a different part of town. Okay, all right. There are athletes out there that have never been hurt. They've never been injured. They get injured for the first time, right? And it doesn't just affect them physically. It affects them mentally. They expect their progress to be linear. They compare themselves to other people. They ignore sort of the mental aspect of their injury. How do you deal with that?
Yeah, I have like first timers all the time. And I find it incredible where someone can be in their 30s and they've never had an injury. Like what?
Yeah.
How fortunate. Wow. I mean, it's incredible. But at the same time, I respect it and I just walk them through it as best I possibly can. And it's devastating for people. People are emotionally traumatized, and even sometimes when they heal, like for example, the first time ACL tear, okay? Or a pec rupture. When they heal, some people can't go back to what they were doing. They have a phobia, like a kinetic phobia of being active again. So yes, it's hard for first timers who get hurt, but we as physicians and as you are, we help people, we hold their hand, we get them through it. I mean, isn't that the best part about what we do?
Yeah, it is. It's the greatest part about what we do is supporting our patients in a way that allows them to continue living their life as they want to.
Yeah, it's absolutely great.
I mean, life is really, it's not about like doing well all the time. It's about how are you going to deal with adversity? How are you going to deal when something goes wrong, right? And I think that aspect of coaching somebody through that, you seem to have mastered, but it's a very important aspect of what we do on a daily basis.
It could be taxing, especially when patient expectations are not quite aligned, or they don't square up with reality. There's one thing that I learned from my partner, Dr. Germanovich. He's a pain management partner. He's like, I use humor. That's what I do. I just, I don't get caught up in the weeds with them. I'm compassionate. So then it's actually helped me, that type of role model who deals with the chronic back pain patients, and then I see how he interacts with patients. It's actually helped me interact with patients that normally would be kind of hard to deal with, especially in this in our environment where we have to see patients relatively rapidly. Sometimes you don't have time to sit there and chat too much, but there's different approaches, right? There's different approaches which you learn over time.
The way that you think in orthopedic surgery, I actually think is unique. I got a lot of boys that are orthopedic surgeons. I wanted to do orthopedics at first. The way that you're thinking, I think, I'm not saying it's above all the other orthos. They all do a great job. But I just think that you're trying to apply cellular biology to what has become a very mechanical field. And I think that that's amazing that you're doing that.
But there's a relationship, right? I mean, there's a relationship with obesity, I'm sure, with lung disease probably. And after 23 years, I think most orthopedic surgeons will start to see that.
Yeah.
You start to recognize patterns.
Yeah.
And it's up to you whether you're going to do something about it.
Is there a patient case that you could think of that was really positive, where I did this, I was amazing, patient has a great outcome?
I had a couple of cases like that where I was more proud. In every case, I'm happy, right? Every case is a high five for me, every positive treatment. But there's a couple that stand out, like about 5 years ago, a patient came to me. His name is David Taylor. He's called Magic Man. And he is a world-class wrestler. He was going to the Olympics. And he just suffered an ACL tear.
Oh.
Just maybe a year before the Olympics or less.
And the ACL is the anterior cruciate ligament.
It's the anterior cruciate ligament, commonly injured in athletes, especially soccer players, volleyball players. So it was very challenging and anxiety provoking, by the way, because this guy's putting his trust in me, and he's been thinking about the Olympics all his life, right? Like I'm sure most of these Olympians have, because it takes a lifetime to get to that point that they can compete at that level. So I thought, oh my God, Jesus, I'm going to be doing this guy's ACL. But I thought, I'm a well-trained guy, and I know the concepts, and I've done hundreds and hundreds of them. And I got him through the surgical procedure, and it's not just the procedure, but also emotionally, like what we talked about. We're dealing with a guy that's wondering if he's going to be able to bend his knee well enough, to do what he does. And he went and he won the freaking gold medal.
That's pretty sweet.
Dude, he won the gold medal the last 4 seconds. It was an amazing wrestling match against a well-known Iranian wrestler that was world renowned in his country. And it was the last 4 seconds, and he's on his knees. His knee functioned perfectly.
That's pretty sweet. That's an amazing story.
That's gold, man.
Yeah,
that was gold.
That was Olympic gold.
That was Olympic
There's
gold.
no better.
He raised his hand, and I raised my hand at the same time.
That is crazy.
When you're dealing with high-level athletes, the guys that are on TV, and they're also relying on their body to do what it's meant to do, it puts a lot of pressure on orthopedic surgeons. All these orthopedic surgeons that take care of high-level athletes, they have a lot of pressure.
Yeah.
It's actually it's a high-pressure situation.
If you had a call to action to say to patients out there, athletes out there, what would you say? What gives you energy and passion? What is it that you want to say to them?
I say, do everything you can to not see me. And you can do that. And you can do it. The majority of injuries are preventable if you think about it early in life. So if you're in your 30s, well, first of all, if you're in your 20s, just don't do high risk stuff. Don't jump off buildings and crazy things like that. Okay. And once you're in your 30s, that's where things start to happen without you realizing. What can you do to not see someone like me? Number one, you take care of your diet. So you eat well. You don't gain weight or try to keep weight down and manage it. Every year, you have to check your weight. If you're 5 pounds overweight every year, well, think about it. 10 years from now, you're going to be 50 pounds overweight. That's a lot of weight. And it's not about just the weight, it's the metabolic problems that are associated with it. If you have suffered an injury already, like an ACL injury or a meniscus tear or even patellofemoral joint pain, you might be actually wearing out your anterior knee if you have patellofemoral joint problems. So be aware that there are preventative things that you can do. See a physical therapist the moment you start to kind of have some aches and pains, because 10 years from now it might be different. So take care of your health, take care of your metabolic health, and see a good cardiologist or internal medicine doctor to check your lipids. Make sure that your LDL is not elevated, because cholesterol does matter, and stay as healthy as possible and move. Get out to the park and move. Sitting on the sofa eating Doritos and playing video games is going to lead to me. That's where that's going to lead. That's the best advice I can give people. Don't see me.
Well, even though we don't want to see you, where can we find you, Steve?
Well, I'm really easy to find on social media. I've been doing it for a long time. My website is myorthodoc, or Instagram. I'm very easy to find. I'm pretty active on Instagram. I use it for communicating my educational information, which is my name, Steve Mora, MD. And if you are a bodybuilder and you tear your pec tear MD on Instagram as well. My practice is in Orange, which is my orthopedic practice, and then I have my PRP office in Santa Ana, my PRP peptide office. Come and see me.
I'm coming.
Hey.
Thanks, you guys, for watching. We're on Instagram at the Health Exchange Podcast. Get us wherever you get your podcasts: Apple, Spotify, YouTube, iHeart, all the places. Appreciate you guys being here. Steve, I appreciate you spending your Friday afternoon here with us.
Hey, thank you very much, Jamie. Absolutely great.
Thanks
pleasure.
a lot.
Thank you.
Yeah, we'll see you guys Thursday morning, 6 a.m. Pacific, 9 a.m. Eastern Time, every Thursday. Take care.